Okay, so I'm going to talk about a study. There are various people in the audience who have helped a considerable amount, so there's a very large team of people that were involved with this. So this was deliberately designed to meet three concerns that the NHS seemed to have. One was that people go too often to same-day care, emergency care. That's number one. Secondly, they wanted to see introduction of digital technology. So in terms of the JLA, which JLA top 10 does it address? It addresses partly number one and a lot number 9, if you look on your list. And the third thing was, what about saving money? So I'm going to suggest that we might have achieved all three of those things. But as so far, there's no sign whatsoever of any action to implement it into practice. So does the NHS really want to save money? Does it really want to do something about urgent care? Does it really want to do anything about digital technology? I'll just leave you that thought. There's some wonderful cartoons that came from our PPI people, so you'll see them cropping up, and I've unashamedly borrowed some of the slides from my research staff who've gone around presenting some of this before. But health anxiety is a concept that in my medical school doesn't even get taught to doctors and nurses. But you can't believe that it isn't. So it's a high-level preoccupation and worry about having or acquiring a serious physical illness. Not only a specific one like hypochondriasis, but just generally. They're easily alarmed about personal health, and as a direct consequence, they may excessively check themselves, reassure, seeking doctor's appointments or looking at the internet, or they can avoid healthcare information. So sometimes the same patient will go for a fairly trivial problem, but ignore the big problem that they should be going to seek help. And the preoccupation with health is distressing most of the day, every day, for at least 6 months, is part of the definition. So all of us get alarmed now and then by the odd symptom. This is more of a preoccupation. So why health anxiety? Health anxiety is not good for you. One of the things that I keep hearing from doctors is that these people will never get unwell. They'll never be ill. But actually, that's not what the evidence suggests. So it nearly doubles the risk of hospital care or death from heart attacks in healthy people or people who had a heart attack. It's particularly bad for your heart. There's good evidence of clinical and cost effectiveness from face-to-face and internet CBT. In fact, there's a recently published meta-analysis of 14 large randomized controls showing a large mean effect. Unfortunately, most of those people were volunteers or people in mental health services who already knew they had health anxiety, not people who were not sure about that in the first place. Medical explained symptoms as a group, of which health anxiety is only part, costs a lot of money. So even in 2008, it was supposed to be £3 billion per unnecessary costs. There is a reluctance to receive face-to-face psychological therapy. So I've tried to look to see in IAP services, where health anxiety has long been a core part of that, how many people actually have a diagnosis of this. And bearing in mind that they might have been labelled as something else in IAPT, it's still a remarkably small number of people that actually get any help. And this is borne out by some observational work. So one thing we did with our PPI, we did a previous study where we asked people, what would you be willing to receive? And interestingly, remotely delivered therapy, which could be telephone or internet, was selected only as one of two options. The other option being to see somebody face-to-face in their own GP practice. But that would be enormously expensive and impractical. So we went for the remotely delivered therapy. Here is what you could achieve if you, this is a study of screening medical clinics. It is cognitive behavioural therapy for health anxiety versus standard care delivered in medical outpatients. The impressive thing is not only that it improved people at 1 year, but also 2 years, and even 5 years later, they're still improved and they're saving money. The big problem is to get 400 and odd people into this study, they had to screen 31,000 people, and I can't see the NHS screening people for this problem in that way. So our study was compared to usual care. Can CBT offered to people by video conferencing, or if they really won't do that, by telephone, plus usual care, be effective versus usual care in relieving distress? And the primary outcome was health anxiety at 6 months, improving physical and emotional health. And also, does it save costs? So will it be cost reducing or cost effective from health, social and personal perspectives? So this is the methodology. It was a randomized controlled trial. We needed we slightly over-recruited. We were supposed to be 148 people, and we got 156. We recruited 33% who were eligible. I've done previous studies of this and only managed to succeed in getting 7%. So, and best in the literature up to now has been 18%. So we managed to do better. They were aged 18 and over. They had more than 2 unscheduled attendances in the last 12 months. People think that's not very many, is it? But our record systems are terrible at recording emergency care. So I knew that from previous studies. If you ask people, they've actually sought a lot more care. They had no identified pathology at these 2 unscheduled attendances that counted for this study. They scored more than 18 on the health anxiety inventory. Why? Because that's the IAPT criteria. We followed them up for 3, 6, 9 and 12 months, and they were delivered into these 2 treatment arms. We use a network of practice. So this is our co-production bit. We call it a network of practice. Patient and public representatives, technologists, NHS, primary care clinicians and support staff, hospital staff were also involved, the research team. We met at roughly 3 monthly intervals. And really this was to get it right, what to say to people, how to present it, all those kind of things. I'm not going to spend long on it because I haven't time. We identified barriers to recruitment. This was an iterative process. Co-production shouldn't just end in the preliminary phase. You need to tweak it and continue to tweak this to make it work. We found there is a particular issue with this condition, that clinicians are very afraid of complaints, and receptionists are afraid of complaints. Complaints are an enormous problem, especially in primary care. So they didn't want to upset anything, and that's quite a big barrier. So the non-stigmatizing explanation, help to cope with your distress or worry about bodily symptoms, seemed to work. It didn't upset anyone, and we gauged people as we hoped in the trial and therapy. So we recruited to time and target. So this is the intervention. There's 2 of our research staff. There's Sam wearing the headphones, who's the lead therapist for the study. There's Shireen, who's the lead research assistant. And that to the left is some of the interactive working that you can use. This is the WebEx system used for business. In terms of technology, this is old hat. Many of those of you who are interested in technology will think this is very old-fashioned. But one of the advantages for the NHS is it's tried and trusted. So we moved on. These are some of the results. Again, a lot more than 2 attendances, as I thought. You know, actually people had attended a lot more than people realised. So at least 5 times on average. There's a range. Some of them are at very high rates. Most of that was in GPs, primary care. We weren't very successful recruiting in A&E departments, and that's, I'll come to that if you want me to as a question. Relatively young group, that would be my main criticism. But look, there are still people nearly 80 or over 80 in this study. Mainly female, as you'd expect with this condition, quite a lot of people employed. If you look at the levels, we're in the severe range of health anxiety, we're in case levels of general anxiety, depression, somatic symptoms, and we are fairly low quality of life. And so work and social adjustment, that's just about in the impaired range, significant impairment range. So if they're working, they are struggling. So here are the results. So I have to garble through this a little bit. So we saw approximately a 3-point difference between the groups at 6 months, 9 months, and 12 months. And that 6 months was the primary outcome. Rather like the CHAMP study, it's a mirror image of the CHAMP study in some respects. There were improvements in generalized anxiety, depression, and general health, but they only appeared at 12 months once the health anxiety was reduced. We only saw trends for reduced symptoms and improve function. But nevertheless, the CBT group did do better than the treatment as usual group. At least there was a trend towards that. So here is the cost issue. This was designed to pick up people who cost a lot of money to the health service. So this treatment, without going into a huge amount of detail, saved more than £1,000 per patient. If you use NICE methodology, which also includes the fact that these people also improved in quality of life, then it's actually £3,000 per patient using the usual assumptions that they make. And down there, at the bottom, those are all the simulations. And you can see the one that you really want is the one that is southeast, and it's predominantly there. That means it both saves money and improves outcome. So there we are. Doctors recognise people with health anxiety. I should have said that. Most of these patients were not picked up by any form of screening. They were just picked up in their routine consultation. GPs and doctors know when people have this. And 90% accurate. We gave a non-stigmatizing explanation. And I think this is very important. The CBT delivered remotely for their convenience. These are predominantly people overstressed, very busy lives. They need it when they need it, and they mostly wanted it in the evening. A limitation was a low rate, particularly of the completion of health economics interviews, but there are lower rates of follow-up than one would like. Samples biased to a mean younger age. That wasn't so much us. I wonder if it's to do with the GPs and people thinking that this is better for younger people, but there are plenty of older people as well. It was clinically effective for at least 12 months. It's debatable whether it would last longer. That needs to be trialled. And it reduces worry to manageable levels. We're not claiming this cures anyone. It just reduces worry to a manageable level. And it saves money. And the interesting thing is that to do that, the mental health services or IAP services would have to provide this treatment. The savings are not in mental health services. Their savings are in primary care and acute hospitals. This makes some sense about the idea of it working as a healthcare system. If you looked at it as a budget, just as a mental health budget, this just costs you money. It doesn't help you save anything. So that's a challenge, because we're not very good at doing services like that. And it's cost effective by NICE. Whatever assumption you make is robust to every possible assumption that we tried. And I think it's ready for implementation. But there again, implementation is a huge challenge. But I think the aim was to produce something implementation ready. So there we are. Thank you.